Hello everyone, welcome back. Today we'll discuss hypermagnesemia, an electrolyte disorder that is relatively uncommon but can rapidly become life-threatening due to its effects on the neuromuscular and cardiovascular systems. In this video we'll cover causes, clinical manifestations, ECG changes, diagnostic approach, evidence-based management, and important clinical pearls. Let's begin. Hypermagnesemia is generally defined as serum magnesium greater than 2.5 milligrams per deciliter or 1.05 millimoles per liter. Normal magnesium level ranges from 1.7 to 2.4 milligrams per dl, or 0.7 to 1 millimole per liter. Fortunately, clinically significant hypermagnesemia is uncommon because healthy kidneys efficiently excrete excess magnesium. Therefore, most patients who develop severe hypermagnesemia have renal impairment combined with excessive magnesium intake. Let's divide the causes into three categories. 1. Increased magnesium intake. This is the most common cause. Examples include magnesium-containing antacids, laxatives such as milk of magnesia, Epsom salt ingestion, intravenous magnesium sulfate therapy, and total parenteral nutrition with excessive magnesium. Remember, these rarely cause toxicity unless renal function is impaired. 2. Decreased renal excretion. This is the major risk factor. Examples: acute kidney injury, advanced chronic kidney disease, and patients on dialysis. Even normal magnesium intake may become excessive in severe renal failure. 3. Increased release or reduced elimination. Causes include tumor lysis syndrome, rhabdomyolysis, adrenal insufficiency, lithium therapy, familial hypocalciuric hypercalcemia, and hypothyroidism, rarely. Symptoms correlate reasonably well with serum magnesium levels. Mild elevation, 2.5 to 4 milligrams per dl. Patients may be asymptomatic or develop nausea, flushing, warm sensation, mild hypotension. Moderate elevation, 4 to 6 milligrams per dl. Now neuromuscular effects become apparent: lethargy, drowsiness, loss of deep tendon reflexes, muscle weakness. Loss of patellar reflex is often an early clinical clue. Severe elevation, above 6 to 8 milligrams per dl. Patients develop marked hypotension, bradycardia, respiratory depression, paralysis, somnolence, and heart block. At levels above approximately 12 milligrams per dl, patients may develop complete heart block, cardiac arrest, and coma. Remember, clinical severity depends not only on the magnesium level but also on how rapidly it rises. Hypermagnesemia produces ECG findings similar to hyperkalemia because both depress myocardial conduction. Common ECG changes include PR interval prolongation, QRS widening, bradycardia, AV block, prolonged QT interval in some patients, eventually complete heart block or asystole. Continuous cardiac monitoring is essential in symptomatic patients. The diagnosis is straightforward. Confirm elevated serum magnesium and simultaneously assess renal function, potassium, calcium, phosphate, creatinine, and ECG. Remember an important association. Hypermagnesemia often coexists with hyperkalemia, hyperphosphatemia, and hypocalcemia, particularly in advanced kidney failure. Always identify the source of magnesium exposure. Many patients are unknowingly taking over-the-counter magnesium-containing medications. Management depends on symptoms and renal function. 1. Stop all magnesium intake. Immediately discontinue magnesium antacids and laxatives, intravenous magnesium. 2. Stabilize the myocardium. For symptomatic patients with ECG changes or severe toxicity, administer 10 milliliters of 10% calcium gluconate intravenous over 5 to 10 minutes. 1 gram calcium chloride via central venous access. Calcium does not lower magnesium levels, but it antagonizes magnesium's effects on the heart and neuromuscular junction. 3. Increase magnesium elimination. If renal function is preserved, administer intravenous isotonic saline followed by loop diuretics such as furosemide. This promotes urinary magnesium excretion. 4. Hemodialysis. Patients with severe renal failure, life-threatening symptoms, very high magnesium levels, and failure of conservative therapy should undergo urgent hemodialysis. Hemodialysis rapidly removes magnesium and is the treatment of choice in severe toxicity with kidney failure. Before we finish, here are 5 high-yield pearls. Hypermagnesemia is uncommon because normal kidneys efficiently excrete magnesium. Always suspected in patients with renal failure receiving magnesium-containing medications. Loss of deep tendon reflexes is an early bedside clue. Intravenous calcium reverses toxicity but does not remove magnesium. Hemodialysis is definitive therapy for severe hypermagnesemia in patients with impaired renal function. Hypermagnesemia may be rare, but missing the diagnosis can lead to respiratory failure, complete heart block, and cardiac arrest. Early recognition, discontinuation of magnesium exposure, calcium administration when indicated, and timely dialysis can dramatically improve outcomes. Thank you for watching. If you found this video helpful, please like, share, and subscribe for more evidence-based videos on critical care medicine. See you in the next video.